Hey, what's up, everyone? Welcome back to ShockDoc Medical. I'm Dr. Raad, your go-to guy for diving into the wild, unexpected corners of medicine. Today, I've got a super intriguing topic for you. We're talking about the ins and outs of examining the scalp and hair. Now, have you ever wondered why someone might be losing hair without even realizing it until it's too late? Or how a subtle change on your scalp could be a red flag for something more serious? Buckle up, because we're about to break it all down. Imagine this. You're noticing a bit more hair in your brush each morning, but you can't really tell until, bam, your density's dropped by nearly 50%. Crazy, right? Today, we're getting into the nitty-gritty of how to properly examine the scalp and hair, what to look for, and how you as a doctor, or even just a curious person, can pick up on the subtle clues of alopecia. And trust me, this info is gold for anyone dealing with hair thinning, excessive shedding, or even complete baldness. All right, so here's what we're unpacking today. We're going to chat about why a full dermatological exam of the scalp isn't just for looking good. It's essential when a patient complains of hair issues. We're talking about everything from diffuse hair loss to localized patches. We'll cover the difference between non-scarring and scarring alopecia, and why sometimes you might not even see the hair loss at first glance, because up to 50% of hair density can be lost before it becomes obvious. Plus, we're diving into the practical side, what to check for on the scalp and hair shaft, and even some neat little tests like the hair pull and hair pluck. So whether you're a seasoned doc or just a curious mind, this episode is loaded with useful, real-world info. Let's kick things off with the basics. When you're examining a patient complaining of hair thinning or excessive shedding, the scalp examination becomes a critical part of the overall dermatological exam. Now, here's something that might surprise you. Hair loss, or alopecia, can be caused by a whole host of factors. We're talking fungal infections, drugs, even systemic diseases. And it's not always a uniform process. Sometimes the loss is diffuse, sometimes it's patchy. In fact, a patient might be shedding a lot without it being obvious to the physician because the hair density can drop by as much as 50% before thinning really shows up. And hey, it's not just about the scalp. This can affect your eyelashes, eyebrows, beard hair, or even body hair. Now, one of the big things we need to figure out during our exam is whether we're dealing with non-scarring or scarring alopecia. In non-scarring alopecia, you can still see the hair follicles, meaning there's hope for regrowth. But in scarring alopecia, the follicles are essentially obliterated. So when you're looking at the scalp, ask yourself, is the hair loss complete? Is the density reduced? Is it diffuse or patchy? And is there any sign of regrowth? Also, consider if the hair loss affects specific parts of the scalp. For instance, in men with androgenetic alopecia, the vertex and temporal areas are usually hit first, so be sure to check the frontal hairline. And here's a cool tidbit. If you see that white hairs are spared, it might point towards alopecia areata, since those white hairs usually stick around when the pigmented ones drop off. Next up, take a good look at the scalp itself. Does it appear normal, or is it erythematous? That's red or scaly? Look out for follicular pustules, perifollicular erythema, or even follicular plugging. And what about the hair itself? Are there broken hairs? Is the hair shaft smooth or rough? And if you happen to see those little exclamation mark hairs at the edge of a patch, short hairs that taper to a point, you might be looking at a classic sign of alopecia areata, even though it's not super common. Now, if you're suspecting scarring alopecia, one key diagnostic sign is the loss of follicular ostia. Grab a hand lens or a dermatoscope and examine the involved areas closely. Other indicators can include epidermal atrophy, which is when the skin looks shiny and thin and wrinkles excessively when you pinch it. Parafollicular hyperkeratosis, boggy swelling, inflammation, follicular plugging, or even colloidal scarring. If you're still on the fence, the gold standard is to confirm with a biopsy. Take 2 deep 4mm punch biopsies from active, hair-bearing skin. One should be sectioned vertically and the other horizontally. This gives you a clear picture of what's happening down at the follicle level. Now, I know all this sounds a bit like reading a medical textbook, but let me break it down with a personal twist. Imagine you're a detective, and your job is to uncover clues from a crime scene. Except here, the crime is hair loss. Every little detail, from the pattern of the loss to the state of the scalp, is a clue that can point you toward the right diagnosis. And honestly, that's what makes this work so fascinating. Another key part of our exam is the hair pull test. Here's the deal. You gently pull a cluster of 25 to 50 hairs from the scalp by running your fingers from the base to the tip. Normally, you'd only see 1 or 2 hairs come out. But in cases of active telogen effluvium, you might yank out at least 10 hairs. Then, under the light microscope, you can see that these hairs are in the telogen phase, the resting phase of hair growth. And if you're really looking to dig deeper, you can perform a hair pluck test, also known as a trichogram. In this test, you forcefully pluck a tuft of 10 to 20 hairs using something like artery forceps. Lay those hairs out on a slide, cover them up, and examine them under a microscope. What you're looking for here is the ratio of anagen, growing hairs, to telogen, resting hairs. Normally, the ratio is about 4 to 1. But if you see that more than 25% of the hairs are in the telogen phase, you might be dealing with telogen effluvium, where the ratio is either decreased or even reversed. And get this, the telogen hairs have these club-shaped root bulbs with little pigment, while the anagen hairs have much smaller, softer bulbs that are easily distorted and sometimes even have bits of the root sheath clinging on. Now, why does all this matter? Well, for patients, these diagnostic details are the first step towards getting the right treatment. And for doctors, especially those in primary care or dermatology, having a thorough, systematic approach to examining the scalp can make all the difference in catching these conditions early. When we diagnose conditions like telogen effluvium, androgenetic alopecia, or even alopecia areata correctly, we can tailor our management strategies accordingly, even if this article doesn't dive into the specific treatments or medications. But knowing what you're dealing with is half the battle. Let's be real. Losing your hair can be a major blow to your self-esteem, and in some cases, it's a sign of underlying health issues that need attention. So by mastering these examination techniques, we're not just improving our diagnostic skills, we're directly impacting people's lives. All right, folks, that's a wrap on our deep dive into scalp and hair examination. I hope you found this breakdown as fascinating as I do. Remember, whether you're a healthcare professional or someone interested in understanding the finer details of medical diagnostics, every little detail counts. If you enjoyed this episode and learned something new today, please hit that subscribe button, smash the like, and drop your thoughts or questions in the comments. Let's keep this conversation going. What's been your experience with hair loss, and what other topics do you want me to tackle next? Next week on ShockDoc Medical, we're going to explore another groundbreaking discovery that might just flip the script on how we understand a common medical condition. Trust me, you won't want to miss it. Thanks for tuning in, everyone. Stay curious, stay informed, and keep questioning the world of medicine with me, Dr. Raad, here on ShockDoc Medical. Until next time, take care and keep rocking that health journey.